president of the African family join us. Oh, sorry. The virtual, I hope the presenter of Capipa is available virtually. If you are there, please raise a digital hand so that we Dr. Bolari, please join Dr. Bolari.
Medical elders, my colleagues, good afternoon. Presenting a paper conducted almost during the COVID period. So it's titled Health Workers' Perception of Government Response to COVID-19 Outbreak in Lagos, Southwest Nigeria. I'm quite sure you are all aware that we are still in the COVID period. And it's very important that when COVID came, we didn't know much about it. This is my presentation outline. It was such a strange disease that the global world woke up to see that China has accepted a strange visitor known as the novel coronavirus. Because it was first recognized in China. It was said to be a zoonotic pathogen, but at the same time, it was transmitted to man to man. Because it was a novel virus. Not much was known about the signs, symptoms, prevention, so everybody was just trying everything they could do. And in the January, very early January, WHO declared it a public health emergency in February 27th. And then today we have staggering statistics shown over there. So it's very important that we know that things, what were done, a lot of measures were taken in response to reduce the spread of COVID-19. Since many things were not known about this disease, we have a lot of countries, exactly what is happening now, banning countries, strengthening of surveillance, banning of in-flights from several countries, establishment of a task force to monitor all the activities of the various sectors, multi-sectorial sectors, and then, because not much was known about this, a lot of trainings were done to sensitize health workers, even communities, to know about this disease, and then provision of personal protective equipment. Of course, you all know that as health workers, we are as frontline workers, we are the main culprits of this novel virus. A lot of health workers did not know what to do because it was new. Some of them succumbed to the disease. In fact, in the early 3 months of the disease, in abroad, China, US, a lot of health workers lost their lives. And a lot, because of some have comorbidities too. So it was really a strange disease to some of us. By the time it got to Nigeria too, because China was already in front, they were doing a lot of studies, so they were able to do some studies and they were able to identify the symptoms, the mode of transmission. Of course, because of that, reports of physical and mental infections were reported among the health workers. A lot of morbidities and also infections of the workers as well as their families. So it was really a tough situation for us in Lagos and even Nigeria. So as of February 22nd, more than 111 million cases have been reported. But as we speak today, we had Lagos has reported about I think 152,000. Nigeria has reported 152,000 and over 1,000 there. Lagos as epicenter also has recorded an increase. Now we know we have several variants, so it's a lot of problems. The challenges the doctors had then was because there was little knowledge about this, no PPE, the government was paying very meager amounts for hazard allowance, so many people did not want to stick out their neck. Some people had to go on leave. Those that could not go on leave, they were working back to back, a lot of restrictions among the health workers. So we now decided to look at the perception of these doctors. How did they feel about the various responses of the government, which refers to at the state level and at the national level? It was a descriptive cross-sectional study using a web-based Google format, and a total of 202 respondents pulled from the private as well as the public sector. and data analyzed and presented the tables, association of categorical variables established, and the level of significance, statistical significance was at P less than 0.5. Of course, research and ethical committee of lawsuits. So these are results, demographic characteristics. Then we also talk about the distribution of respondents' knowledge. We found out that because several trainings were going on, a lot of government agencies, online training. In fact, that was when many people moved to online activities. So the health workers were able to get some knowledge. So we found out that their knowledge was very good, and also their response to knowing the method of transmission, symptoms, preventive measures. Though they knew the preventive measure, but the materials, PPEs to use, were not available then. So in essence, the thing was that the perception of health workers to government response was very suboptimal then. But they had improved system in terms of health system, strengthened system in other developed countries. The government response was better compared to our own country or Lagos State, because they had structures on ground in terms of emergency response, epidemic response. So everything was on ground compared to what we had at the early part of the COVID outbreak. So in conclusion, we knew that the knowledge of COVID-19 among the health workers was very good. Perception towards government response was, however, suboptimal. So what we are saying that government has moved forward. We're seeing in COVID period we have several variants, Delta, Omicron. We don't know the next variant that will come. Those vaccination is on, but our people are still not very favorable to all these things. Even in terms of prevention of COVID-19, in terms of use of personal protective equipment. So we are recommending that government and other relevant stakeholders should prioritize health of health workers and other essential workers. Because during this period, we lost a lot of health workers, a lot, at the national level, even in Lagos State. So adequate investment should focus more on the health systems. And I know government is doing now, presently, as we know now, they are doing a lot of work to improve the health system, strengthening of the primary health care system, because that is the first step to receiving health care in the scheme of things. So I know things are getting better, but we need to do more. In terms of response to epidemics, we need to start training people on emergency medicine. Presently, we have a very limited number of people that are specialists in emergency medicine and responding to epidemics. So we still need to encourage that some of us female doctors can also go into that area. And then we need to also continue to strengthen relationship between doctors and government. You know, government and doctors, they are like Tom and Jerry. Strike today, strike there. So it's always a problem. So we need to try and engender that relationship between the doctors and not just doctors. Because what we did was not all health workers. Because if we do not take care of them, if any epidemics come, I don't know how we are going to address it. Of course, a lot of things have happened during that period. Most of them were hard work. I cannot pinpoint that we were able to build an infectious disease hospital, despite the resources that we spent on the COVID. So if another, thank you very much, ma'am. So these are my references, and thank you for listening.
Thank you very much, Dr. Bakari. Yes, forgive me for being a harassment officer. So I will harass anybody else who spends more time than necessary. All right, moving forward. We're going to have a little speech The next advertised presentation has already been taken, was taken in the morning. And so we will call up the presenter who should have presented in the morning but couldn't do that to please do so now. And so I'll call on the presenter of the work titled Self-Stigma and Treatment Challenges Among Adolescents and Young People Living with HIV in Lagos State, Nigeria. And the authors are Oluchi J. Kama Okafor and Zena and Olakunle.
Attention program. I decided to present this project just to let people know that there are a lot of opportunities available in the social sector for medical doctors, medical personnel that we can tap into, and a lot of grants available that we can tap into to project ourselves. So to talk about it, to declare that this project was sponsored, fully funded by the United States African Development Foundation, was fully monitored by the Lagos State Employment Trust Fund, and Diamond Development Initiatives, who were the monitoring and evaluation experts. So it's a program around employability. And you know, when we hear employability, I think the things we get to hear is that they're sharing marijuana, they're sharing things like tricycle, motorcycle, you know, and there are lots of things we can actually also do in the health sector. It's not left to people who cannot, who didn't study, who didn't go to the university. There are other things we can do. So the background information is that despite government effort to provide healthcare services, we found that during COVID, the private providers were also saddled with the responsibility of taking care of patients. But besides that, there was a struggle for information. A lot of associations had to go up to television stations and talk to people about the COVID pandemic. The media had to be trained. So we needed, in the hospitals, we needed a lot of people to tell stories and tell people about COVID besides treatment. A lot of information was going on around WhatsApp. This job is not something that only doctors can do. There are people who studied paramedical courses, social courses that can be properly trained, and they will be able to give good information to the public. So the objective of the project was, one, to provide young people between the ages of 20 and 35 relevant skills in the healthcare system, in the healthcare industry, as support staff, front desk, people, social media managers, infection prevention control, you know, other things around the hospital environment besides treating patients, and training them to be employable also in the healthcare sector, and providing job opportunities for young Nigerians, especially females, and ensuring self-development and empowerment for female young providers. So the recruitment, the process to it was recruitment, training, internship, and full employment. It was an 8-week program which was pilot. That means that we prepared an 8-week program of training which lasted 2 months. Then the internship lasted 3 months before they went on to full-time employment. Recruitment was largely online through the Lagos State portal, followed by an 8-week physical lectures. Physical was 60% and virtual 40%. And the methods were face-to-face videos, meeting application, focus group discussions, and field trips. Monitoring and evaluation was done weekly by the partners via phone call, spot checks to the facility, and reporting systems that they had already created templates for. So what was the result? The result, we eventually trained 96 people. We eventually trained 96 people. We were able to certify 76 out of them because there were certain metrics before they were certified, and those that now have permanent jobs are 45, meaning that 59% of them eventually were able to go on to permanent jobs. The monitoring and evaluation was done by approval of the curriculum and CV of trainers, physical due diligence by the USADF at our training center, and the LSETF with our training venue and the COVID-19 protocol. Number of children attending, the students attending lectures daily, the attrition rate, and the number of internship placements. Then thereafter, the number of people who had full employment post-training. The challenges that we had during the program was that the mindset of youth unemployability. They feel that their first job they must earn 250,000 300,000. Then the ability to speak and write correct English, despite the fact that people said they were graduates, was a big deal. So we had to also look into giving them skills to write. Then we had decorum and skill set for employability. By the time they were to go to internship, you see guys wearing shorts and saying they are going to work, or girls wearing top that was exposing their belly. So we had to do a lot in the decorum. Then of course, internship stipend by employers. We told all employers, usually private hospitals, people working in the private healthcare sector, to pay at least 30,000 to them to cover their expenses of transportation, which was the bid of challenge, where eventually we got over 50% of them enrolled in different healthcare institutions for internship. The lack of support from government institutions. Despite the fact that the project was being monitored by Lagos State, none of the candidates that came out of the program was able to even intern in any government-placed job. So everything had to go back to the private sector. Then, of course, the shrewd budgets, because the budget was shrewd. One, was a pilot that had never been done before, so they were a bit skeptical about how we were going to manage the funds. The students were provided daily allowance of 1,000 naira every day as transportation, and they also provided internship allowance with 18,000 every day, apart from the 30%. So that made it a bit difficult, especially for people that live in Badagry, Ikorodu, and all of that. So those were the challenges we had with the program. The conclusion was that the 10-month project was a success. Many of them also ventured into entrepreneurship after learning these skills. And at the end, our organization was top-star rated, and I've been engaged for a repeat program. Thank you.
I'm a medical student of the University of Lagos College of Medicine, and I'll be presenting self-stigma and treatment challenges among adolescents and young people living with HIV in Lagos State, Nigeria. Next slide, please. Okay, this is my background. Stigma and discrimination are important, but neglected aspect of living with HIV, especially among the young. The shame, worthlessness, and blame associated with self-stigma prevent HIV treatment among adolescents, leading to suboptimal outcome as the likelihood of discrimination is a barrier to seeking health and medical care. This facility-based descriptive cross-sectional study was conducted among 404 youths, of which 59.7% were females and 40.3% were male, receiving care for in HIV centers in Lagos. It was done using the multi-stage sampling technique. The pretested semi-structural interviewer administered questionnaires was used for data collection. Data we analyzed by the Espresso software. The bivariant and multiple logistic regression was used to test for association and identify prediction of self-stigma and treatment challenges. The level of significance was set as 5 less than -0.05. Okay, the results from this study shows that 68% of the adolescent and young people living with HIV felt ashamed of their status. Over 80% of the adolescent and young people living with HIV blame themselves for their present state, and about 40% of both sex felt that punishment was the best thing to be inflicted on them. Also, 38.6% of the respondents isolate themselves from friends and family because of their positive status. 38.6% and 65.3% are scared of disclosing their status to their family members and friends respectively. The study therefore shows that the proportion of respondents who experience HIV self-stigma is 49.2%. Okay, this table just shows the social demographic characteristics of respondents. Next slide. Okay, so from the table, we saw the majority of respondents, which are 10.3%, were aged between 21 and 24 years old, while 19.8% were below 15 years. In terms of religious distribution, 60.9% were Christians and 30.2% were Muslims, while others 8.9 was other religion. More than half of the respondents, which was 7.5%, had educational level up to secondary school, while 26.7% had education up to the tertiary level. The majority of the respondents, 74%, were single. Here, this table shows the self-stigma among young people living with HIV. Next slide, please. So from the table we just saw, a large proportion strongly isolate themselves from friends, which is 58.4% because of their HIV status, while 18.5% are afraid of disclosing their status to their family members. 59.6% are ashamed of accessing medical care, while about half of the respondents have stopped applying for jobs because of their status. Next slide. Okay, so this is a pie chart that is telling us the overall self-stigma. So 52 points at the end of the study was covered that 52% had HIV self-stigma, which they are battling with, while 48% in conclusion, self-stigma and fear of a negative community reaction can hinder efforts to address the HIV epidemic. Self-stigma affects a person's ability to live positively, reduces the quality of life, adherence to treatment, and access to health services. Next slide, please. So these are my recommendations. The media integration of non-stigmatizing messages into television, radios, social media like Facebook, Instagram, and by using some jingles or some show. This will go a long way to demystifying all the myths against HIV, and also in educating the public about HIV. This will help in reducing the self-stigma and treatment accessibility for better survival among people living with HIV. Since most of us do more of social media and also talking more about it on the media will help people stop stigmatizing. This can be done by government and other non-governmental organizations in society. And most of us also believe in what our religious father tells us. So various religious bodies can also assist by educating their followers during religious gathering on HIV to keep them informed and also prevent stigmatization against people living with HIV. These are my references. Thank you.
My beloved rapporteur, are you still with us? All right, there you are. So, Dr. Bolari will give us a brief summary of the presentations. Thank you.
Thank you very much, my chairman. The first presenter is our beautiful former past president of Lagos State MWAN, our beautiful Dr. Bakari. And her presentation was on healthcare workers' perception of government's response to COVID-19 outbreak in Lagos, southwest Nigeria. And she defined COVID-19, gave us a full history of its origin. Everybody calls it the Chinese virus. She also stated when it was declared a public health emergency in January 2020, meaning that COVID has taken away about 2 years of our life now. And Nigeria's first case was in 27th of February 2020. So she gave us a reminder of how this thing started like a joke. She also talked about the responses of Lagos State government when they set up an incident management system, in which our governor, His Excellency Babajide Sanwo-Olu, was the main incident commander. The federal government's response was also set up a presidential task force. Health workers are actually frontline and high risk. And in December 2020, about 1.4 million health workers were involved. We've been working under extreme conditions, scarcity of PPEs or having to reuse them, and poor remuneration, particularly in Nigeria. So they looked at the healthcare workers' perception of COVID-19, and it was a descriptive cross-sectional study using a web-based Google format form. 402 health workers, not just doctors alone, were involved in the private and public sector. Her results were presented in a tabular form. Overall knowledge of COVID-19 among health workers was greater than 80%, which was very good and encouraging. However, the older age groups had more knowledge about COVID-19 than the younger age group. The average age group was about 31 to 40 years old, with female respondents being more than the male, which we expect. Women are generally more sharper. Doctors were about 31.3% and nurses 25.1%. And the knowledge of COVID-19 was good, but however, the perception towards government response to COVID was rather poor, particularly with laboratory services and the psychological support of not just the victims of COVID-19, but also the health workers and their families concerned. She concluded that knowledge of COVID-19 was generally good, but the perception of government involvement was poor, and not really their fault, because they too were also handling a novel virus too. She also recommended that we should prioritize healthcare and essential workers' health and engender confidence amongst them by training people more in emergency response so that we are not caught unawares again. They should also strengthen the primary healthcare system because that's the first front of call. Healthcare workers and government relationships should be improved so that we are not at the war path with each other. So that was the conclusion for Dr. Bakari's presentation. The second presentation was from Dr. Yetunde Oyalowo, and she talked about the pilot of an employability program to create opportunities for youth, particularly female, as support staff in the healthcare sector in Lagos State. Now, she also showed that there's a lot of opportunities for people to tap into the social space due to COVID-19. People say there are no jobs, but they had a program, the USADF and the Lagos State Employability Trust Fund, that did a program for about 10 months. And what did they do? What were their objectives? They were targeting young people 20 to 35 years old to try and give them relevant skills in the healthcare industry as support staff. Everybody can be a doctor, a nurse, but at least there were so many jobs to do, particularly during this pandemic. So they tried to get people that were unemployed and to train them to fit into these roles. And they targeted more females. They equipped them, they trained them so that they would eventually be employed in permanent jobs. The training was for 8 weeks and 3 months to prepare them for employability. They trained 96 people, 76 were certified, and over 50% of those that were certified eventually got permanently employed. The challenges she noted was that the mindset of the unemployed people was unrealistic expectations of financial reward. They wanted to be paid very high, which was not really realistic. Poor grammar, written and spoken, and these people claim to be graduates. Their curriculum and skill set for employability was also an issue. And internships given by the employers, particularly for the private sector, they needed to encourage them to give these people some stipend. Government support was not there. They monitored, yes, but government support should have been more. Because among those that got the permanent jobs, none of them actually was permanently employed within government. No candidates actually even intend in government parastatals, rather, sorry. And then the budget was shrewd because this is the first time, so they need to monitor everything. So in the conclusion, the project lasted 10 months and it was a success. Most of those that were employed are now entrepreneurs. And the organization that did this have also been rated top notch. So it's a win-win for both sides.